Right now, looking at malignant low-grade gliomas, WHO grade 2, classically of the AMN criteria, grade 2 had one of those features. For WHO grade 1, it had no AMN criteria features. One thing you may need to know is how to identify a pilocytic astrocytoma on histology slide. So this is a good kind of image here. One thing you're going to look for is Rosenthal fibers. That's a buzzword. Also look for a lesion that's in the cerebellum or the third ventricle, and for a young patient that's generally less than 25. Seizures are the most common presenting symptom for a pilocytic astrocytoma. So those red areas there are Rosenthal fibers. For workup, classic imaging, again, MRI. These are generally T1 hypointense and T2 hyperintense. Uh, Non-enhancing with contrast, so again, T1 hypo, T2 hyper. Non-enhancing with contrast pathology, 1p19q co-deletion. 1p19q loss of heterozygosity is improved overall survival. IDH1 mutation status, IDH1 mutation is, again, better overall survival. Oligodendroglioma is by definition IDH mutant and combined 1p19q loss. Risk stratification as per RTOG 9802, which is the Shaw-Buckner trial. High risk is a subtotal resection or age greater than 40. Low risk is gross total resection in age less than 40. So low risk for these low-grade gliomas are young patients who had a gross total resection. Obviously, as is usually the case, extensive resection is better. EORTC prognostic criteria, these are the Satan criteria. You don't hear much about these anymore. Size greater than or equal to 6 centimeters, age greater than or equal to 40 years old, T, tumor crosses midline, A, astrocytic component, and N is neurodeficit, so pre-surgery neurodeficit, including seizures. So score of 0 to 2 has a median survival of about 8 years, versus a score of 3 to 5 has a median survival of about 4 years. Validation study 10.8 versus 3.9 years. So again, EORTC prognostic index, Satan, size greater than or equal to 6 centimeters, age greater than or equal to 40, tumor crossing midline, astrocytic component, pre-surgery neurodeficit. Low risk is going to be score 0 to 2 with about a median survival of 8 years. High risk, score of 3 to 5, median survival is half that. Management, high risk, subtotal resection in or age greater than or equal to 40 years old. You want maximum safe resection followed by radiation, 54 gray at 1.8 gray per fraction, followed by PCV times 6, which is RTOG 9802. If it's IDH wild type, essentially you're going to approach as you would for GBM. So maximum safe resection followed by radiation, 54 to 59.4 at 1.8 gray per fraction with TMZ and adjuvant TMZ. Low risk, so this is either gross total resection or age less than 40. You can do maximum safe resection followed by observation. If greater than or equal to 3 of the 5 Satan features, then perhaps lean more towards doing a radiation of 54 gray. Juvenile pilocytic astrocytoma, you can do maximum safe surgery. You only do radiation if it's multiply recurrent or biopsy only. The dose is 50.4 gray. If there's a recurrence, you re-resect if possible, give chemo. Radiation if they didn't receive radiation the first time. Evidence for low-grade gliomas, RTOG 9802. This is the Shaw-Buckner trial. This is published in New England Journal of Medicine 2016. These were WHO grade 2 astrocytomas, oligoastrocytomas, and oligodendrogliomas that were high risk, meaning these patients either had subtotal resection or they were old. They were greater than or equal to 40 years old. They were randomized to 54 gray followed by PCV times 6 cycles versus 54 gray alone. And what they found here after doing the radiation, which was 2 centimeters to the block edge, which is equivalent essentially to 1 centimeter CTV and a 5 millimeter PTV, is that the median overall survival associated with adding this PCV was 13.3 years versus 7.8 years alone. So it almost doubled the overall survival with PCV. And again, these are low-grade gliomas, but these are high-risk patients with low-grade gliomas. There's a statistically significant improvement in median overall survival and progression-free survival here. On sub-analysis, there's a benefit to PCV only in IDH mutant, again, which makes sense. So the bottom line from RTOG 9802 is adding PCV to radiation improves overall survival and progression-free survival in high-risk patients, meaning age 40 or older, or subtotal resection, low-grade gliomas, but only in IDH mutant subtypes. The Believers trial is next, EORTC 22844. This is low-grade glioma dose escalation. It's a question of the dose of radiation. So Believers trial, the way to think about this is we believe radiation will work, but what dose is best? 343 WHO grade 1 to 2 after surgery. They either got 45 gray, which is a lower dose, or 59.4 gray. There was no difference in overall survival, 59%, or progression-free survival, 49%. Bottom line, no overall survival or progression-free survival benefit to dose escalation to 59.4 gray. The trial also identified those prognostic variables, the Satan criteria: size greater than or equal to 6 centimeters, age greater than or equal to 40, tumor crossing midline, astrocytoma, neurodeficits. 3 out of 5 factors are high risk. The non-believers trial, EORTC 2285, low-grade glioma, early versus delayed radiation. This is a question of timing of radiation. So non-believers is we don't believe radiation is necessary immediately thereafter. Again, believers is we believe in radiation, just what dose is best. Is it 45 gray or 59.4? There's no difference in overall survival or progression-free survival. Non-believers is we actually don't even know if radiation is required. So, again, 311 WHO grade 1 or 2 after surgery of any kind either had 54 gray versus observation or essentially delayed radiation. So if they eventually recurred, they got radiation. The 5-year progression-free survival improved with the addition of immediate radiation, 55% versus 35%, so almost 20%. 5-year overall survival was unchanged though, 66 to 68%. Median overall survival was 7.3 years, so it's not different. 1-year seizures improved, 25% with radiation versus 41% without. 65% of those in the observation arm got radiation at progression. The bottom line for the non-believers trial is radiation improves progression-free survival by almost 2 years, but it does not improve overall survival in low-grade gliomas compared to observation alone. NCCTG trial looked at 50.4 gray versus 64.8 gray. There was no difference in overall survival or progression-free survival at 5 years, but there was an increase in toxicity. RTOG 0424, this is the Fisher trial. This is 129 low-grade glioma patients with greater than or equal to 3 risk factors. Again, age greater than or equal to 40, astrocytoma, crosses midline, size greater than 6 centimeters, or greater than or equal to 6 centimeters, or post-op neurodeficits. Phase 2 trial looking at 54 gray and 30 fractions plus concurrent and adjuvant TMZ. 3-year overall survival was 73.4%, which is better than the 54% historical trial. EORTC 22033, Baumert, TMZ versus radiation for high-risk low-grade gliomas. So these are about 500 patients that are old, greater than or equal to 40. They had a progressive mass, new or worsening neurodeficits, intractable seizures. They got 50.4 gray versus dose-dense temozolomide up to 12 cycles. The progression-free survival was 46 months with radiation versus 39 months with temozolomide, not significant. There was no difference in health-related quality of life or global cognitive function between the groups. Therefore, no statistically significant difference in progression-free survival between radiation and temozolomide, although radiation is favored. In terms of technique and planning constraints, CT MRI fusion, supine aquaplast mask. Dose is going to be 54 gray at 1.8 gray per fraction, all RTOG 9802, right here. IMRT 5 to 7 beams or VMAT. Volumes 54 grays at cavity plus T2 flare. Signal, there's usually no contrast enhanced portion of this scan. Plus 1 centimeter cropped at natural boundaries. Your PTV is a 5 millimeter expansion on that. Again, your chemo times 6 is going to be PCV, 1 cycle is 6 weeks, procarbazine, CCNU, or lomustine, and vincristine. Constraints are as in per high-grade glioma. Overall survival at 10 years for histologic oligos is 75%, for histologic astros is 45%, progression-free survival at 5 years is 50% with observation. Toxicity, 3% get radionecrosis. Radiation does not increase the risk of malignant transformation. EORTC 22845, which is the Non-believers trial, so I should put that right there, had 70% transformation in both arms. PCV toxicity is mainly hematologic and nausea vomiting. Radiation followed by PCV is better tolerated than PCV followed by radiation. 50% will undergo malignant transformation. Follow up again, MRI every 3 to 6 months for 5 years and then annually. We'll also add in the malignant primary CNS lymphoma. Go back to your lymphoma notes for this. 90% are diffuse large B cell. These are generally homogeneous, multifocal, periventricular, crosses the corpus callosum. All are stage 1E. Workup, imaging, MRI brain, MRI spine, PET CT, testicular ultrasound for men older than 60. Labs, you want to get LDH, EBV, HIV, toxo, CBC, CMP. Others are going to be a slit lamp eye exam, 10 to 20% end up being positive here. An LP and CSF cytology and a bone marrow biopsy is optional. You always hold your steroids until after the biopsy. You can get transient resolution after steroids. If the biopsy is non-diagnostic on steroids, you discontinue steroids and re-biopsy on progression. Management of age less than 60 after steroids. RMPV chemo times 5 cycles. If you get a complete response, you do reduced dose whole brain radiation followed by high dose Ara-C times 2 cycles. If you have less than a complete response, and you do 2 more chemo cycles. If you have a complete response after 7 cycles, you get reduced dose whole brain RT, 23.4 gray. If you have less than a complete response after 7 cycles, you get full dose whole brain RT, 45 gray. You can also consider 23.4 gray with a cone down to the gross disease to 45 per NCCN. RMPV is Rituxan, high-dose methotrexate, procarbazine, vincristine every 2 weeks. Option number 2 is high-dose methotrexate times 5 cycles, followed by whole brain RT, followed by Ara-C. If the patient is older than 60 after steroids, they get high-dose methotrexate greater than 500 milligrams per meter squared. If they have a complete response, you observe. If less complete response, get whole brain RT. German study, Lancet Oncology 2010, looked at the role of high-dose methotrexate plus or minus whole brain RT, 45 gray at 1.5 gray per fraction. Whole brain radiation improved progression-free survival, but not overall survival, and comes at the cost of substantial neurotoxicity. This was a bad study. There were many protocol violations. RTOG 9310, this is phase 2, DeAngelis, methotrexate, vincristine, procarbazine, followed by radiation to 45. If complete response, I got 36 gray. Followed by Ara-C. Consolidative radiation is superior in patients less than 60. There's high neurotoxicity in patients greater than 60. Sloan Kettering study is 30 patients. They got RMPV. If they had a complete response, they got whole brain to 23.4. If ocular involvement, 23.4. If partial response, whole brain to 45. All got Ara-C. If ocular involvement, 46. 5-year overall survival is 80%. If complete response, median overall survival is 6 years. Techniques and planning here. Volumes, whole brain including the posterior third of the orbit, put a BB at the lateral campus, cover to C2 to C3. If there's ocular involvement, include the bilateral orbits, so flash the eyes. Dose, reduced dose, whole brain radiation used for complete response is 23.4. Full dose whole brain is 45 gray. Boost residual gross disease, 36 to 45 gray. Toxicity and follow-up, there's high neurotoxicity with radiation, particularly for those greater than 60. Follow-up brain MRI every 3 months times 2 years, every 6 months times 3 years, and then annually thereafter. If there's optic involvement, follow with ophthalmology.